This is a high relevant issue, the name of my topics, because blood pressure control in real-world practice remains suboptimal despite the availability of effective antihypertensive agents. One of the main reasons of this is a poor adherence to treatment. Therefore, it is important not only for choose the right molecule, but also to make the treatment regimen convenient for patients. The arterial hypertension is a chronic disease that requires a long-term, often lifelong treatment. However, it is precisely the duration of therapy that creates the main challenge. The more complex the regime, the greater the risk missed doses, self-disconnection, and irregular intake. In daily practice, this is especially evident in patients with multimorbidity, elderly patients, and those already taking several medications for other conditions. Freeform adherence is not a secondary organization issue, but one of the key determinants of treatment effectiveness. Despite significant adherence, the antihypertensive therapy, hypertension remains one of the leading morbidity risk factor for cardiovascular disease and still often uncontrolled in real-world practice, clinical practice. A significant proportion of patients do not receive treatment, and poor adherence to treatment remains recognized as a major barriers to effective blood pressure control. As current ESC materials emphasize improving treatment adherence is not simply a behavioral issue, but the key factor of therapeutic success and long-term cardiovascular risk reduction. Accordingly, modern treatment should focus on a clear rationale for focusing on strategies with simplified treatment, increased adherence, and improved the implementation of guideline-based care into routine practice. This database presents a summary of the epidemiological burden of hypertension in Uzbekistan among adults aged 13 to 79 years. According to the country profile, the prevalence of hypertension in 2019 was approximately about 38% among the adult population, which is significantly treatment gap and low coverage to effective control. The chart also showed that nearly half of people in the age range have elevated blood pressure, with the estimated prevalence in 2019 in the presented database reaching with the estimated prevalence 45%. The long-term treat from 19 to 29 showed the considerably high and increasing burden considered with global observation that hypertension remains in many regions of Central Asia and Eastern Europe. From a clinical to public health perspective, those data highlights the present large reserve of undergoes or poorly controlled disease, enforcing and need for early diagnosis, increased intensity of treatment, and strategies that optimize long-term blood pressure control. Observation studies shows difference in the adherence to antihypertensive medication across different classes. On clinical practice, significantly difference of adherences to antihypertensive medication across different classes or observation. The lowest adherence is observation for diuretics and beta blockers, and the highest for angiotensin second receptor blockers and angiotensin conversion inhibitors. However, adherence was suboptimal regardless for drug class, as published in Lancet in meta-analysis in the last year. It should be noted that sartans have completed evidence-based to improving the prognosis in patients with arterial hypertension. The unique future of the new lethal status therapy, olmesartan, it is the ability to significantly improve the 24 hours blood pressure profile compared to the sartan, which impact to prognosis of patients with arterial hypertension, especially by reduction average diastolic and systolic blood pressure and BP variability and normalizing the degree of nocturnal blood pressure decline. Olmesartans help reduce the severity of target organ damage and the risk of cardiovascular complication in patients with arterial hypertension. But in the case of effective treatment is adherence that reducing in blood pressure leading to 22% reduction in the stroke rates, ischemic heart disease about 10%, and heart failure about more than 11%. The reason for lack of adherence to treatment can be classified as related to the patients, when patients' absence of symptoms, poor understanding the disease and the necessary of treatment, refusal, regimen complexity, polypharmacy, and high pill burden. The second reason is forgetfulness. It's dependent of comorbidities, including depression, physical and socio-demographic factor. And of course, it's dependent in the practitioner, which more often the clinical inertia, cost, accessibility of medication. Why combination therapy has become the standard approach that treated hypertension? For most patients, monotherapy is insufficiency to achieve target blood pressure, and hypertension is caused by multiple pathophysiological factors, including increased vascular resistance, increasing circulation blood volume, and neurohormonal activation. For this reason, achieved adherence blood pressure control often requires switching from monotherapy to dual or even triple therapy. Importantly, modern clinical care not only promotes treatment intensification, but also simplifies treatment regimen to improve adherence, duration, efficiency under optimal condition. 3-4 fixed dose combination therapy represent a rational shift for balanced therapeutic efficiency with feasibility in routine clinical practice. A fixed dose combination, as shown in systemic review and meta-analysis of randomized and double-blind placebo-controlled trials in adult patients associated with to receive angiotensin conversion inhibitor, angiotensin II receptor blockers, beta blockers, calcium channel blockers, and diuretic, including criteria follow-up duration of until 24 weeks, antihypertensive drug therapy. All patients underwent the clinical attached, and total about 484 studies were analysis, including about more than 100,000 participants, shows that standard dose monotherapy reduced systolic blood pressure only 8 millimeter hydration, with each double of the dose result in the additional reduction on 1.5. Combination one of two drugs at a single standard dose resulted with more than 14 systolic blood pressure reduction, which is doubling of the dose, and both drugs resulting in additional reduction. Each 10 milligrams decreased in the baseline systolic blood pressure, reducing then are antihypertensive by 1 and 1.3 in monotherapy, although differences were observed between drug classes. Significantly difference in the dose response, baseline blood pressure responses relations were observed between the and without drug classes. The main mechanism here is very simple. The fewer pills in patients had to take them, more likely they are taking treatment regularly. There are a few day action to remember, less condition between medication, and it is easy to follow the schedule, especially for the regime is once daily. In additional fixed dose combination of psychological preserved as a simple treatment, and it's a matter simplifying if the treatment regime itself can be improved patient behavior, reduce the frequency of missed dose. Meta-analysis showed that fixed dose combinations are associated with better adherence. One of the meta-analysis different was that almost 15% of the likelihood condition therapy was higher in fixed dose combination group. And more recent systematic analysis showed that single pill combination improved adherence, persistence, and even reduced systolic blood pressure compared with free combination. There is important finding because real-world practice evidence, even and modern improvement and medication taking behavior can have a meaning clinical impact. Improving adherence is differently reflected blood pressure control in the patients free for the effective fixed dose combination dose for beyond dosing coherence, they may improve the patient's real prognosis. The most favorable group considered in patients who are elderly and combination therapy, especially if there are sign a poor adherence. There is also included patients with high baseline blood pressure, multiple combination, elderly patients, and those taking several medications every day. Another important group in patients for whom we already anticipate the need for two drugs for the start. In this situation, initial treatment with the fixed dose combination may be more logical than introducing separate tablets step by step. With two combined therapy, the target blood pressure level is achieved in the more than 16 of cases, and with three component therapy in 19% of cases. With two combined therapy, the target blood pressure level is achieved much more better. The most common used combination are renin-angiotensin system blockers with the calcium channel blockers or with diuretics. There are pathophysiological sound combinations that act of different mechanisms regulating blood pressure. The choice of specific combination depends on the clinical profile of the patient's age, renal function, presence of edema, electrolytes, and comorbidities, and of course, tolerability. In often world, a fixed dose combination is not simply one pill instead of two, but a rational way to intensivity therapy. Despite the fixed dose of combination are not suitable for everyone, sometimes the physician needs to try each component separately, and in some cases, adherence effective one of components requires repeat adjustment of the requirement. In addition of patients is elderly high adherence, the benefits of signification may be less pronounced. 3-4 fixed dose combination should be viewed as a tool of personal therapy rather than the universal solution for all patients. The practitioner algorithm included in real world practice. I would like follow a simple algorithm. If patients needed two drugs, has high risk, or has elderly show poor adherence, a fixed dose combination should be considered first. Next, it is necessary to access not only blood pressure value, but also how the patient is actually taking the medication. It is important to ask about missed dose, side effects, practitioner difficulties, and conference for the regimen. This approach helps not just to prescribe therapy, but to achieve sustained implementation. Why it's matter? Because approximately 125,000 people in the United States and more than 20,000 people Europe annually due to non-adherence. Lack of adherence affect up to 40 to 15% in patients worldwide, regardless of the methods used. The assistant treatment complicated in patients with chronic disease such as diabetes and hypertension. According to the estimated from the study conducted in 2011, 4.6% of global healthcare expenditure, or more than 200 billion USD worldwide, can be saved by improving treatment adherence. In conclusion, I want to say that arterial hypertension requires long-term disciplined treatment. Most patients need combination therapy. Fixable dose combination reduce pill burden and improve adherence. Better adherence leads to better BP control and likely to be better cardiovascular outcome. Those FDC are not merely a convenient prescribed format, but an important tool for improving the effectiveness of antihypertensive therapy. And combination therapy is always more effective. Thank you for your attention, and I'm finished.
Thank you very much, Rana. So I think the questions, we can move with all questions at the end of the session during the discussion. So we can move to the second presentation on Asian consensus on high quality hypertension management. The speaker is Jing Liu. Please welcome Professor Liu.
Thank you so much, dear Chairman and ladies and gentlemen. It's my great pleasure to give us a talk about Asian expert consensus on high quality hypertension management. I'm Jing Liu from Peking University People's Hospital. Could you see my full screen?
Yes.
Okay. This consensus paper has been published in this year's May's online issue of Hypertension Research. This work has been conducted within the frame of a Hope Asia Network, one of the academic organization which is dedicated to reduce cardiovascular events across Asia by precise hypertension and other cardiovascular risk management. As we can see the timeline of the consensus paper, it's about 2 years since we start a kickoff webinar in May in 2024, and after that we have several rounds of multidisciplinary symposium within in the field of hypertension, cardiovascular cardiology, as well as nephrology, and the professors who are dedicated to treatment and management of cerebral vascular disease. And we can see that after about 2 years discussion, we finally submit the draft, and this work was accepted and published online in this year, in 2026, on 12th of May in Hypertension Research. So I will give you a very brief introduction of the contents, including the concept of high quality hypertension management and how to evaluate and what is a strategy to perform high quality hypertension management in Asia. And finally, the third part is focus on the practical protocols during the practice. So the concept of high quality hypertension management is referring to achieve 24-hour and long-term stable blood pressure control on the basis of all office blood pressure at goal to reduce cardiovascular renal complications and deaths ultimately. So we need to promote the use of out-of-office blood pressure, including 24-hour ambulatory blood pressure measurement and the home blood pressure measurement, as well as some validated variables, because this out-of-office blood pressure measurement can provide more information in addition to the traditional office blood pressure. And to use of long-acting BP-lowering medications, we can realize 24 hours complete blood pressure control. And during this time, to try best to reduce blood pressure variability and in the long run to improve time to target range as well as visit-to-visit variability, and to realize a long-term blood pressure at goal to in attention to reduce total cardiovascular complications and deaths. So we recommended individualized therapy based on the blood pressure grading, staging, and phenotyping. This frame has been first proposal by Professor Jiguang Wang about 10 years before, and this time we have some revision and update and detailed for the BP grading, staging, and phenotyping. Just as the picture demonstrated that we need to manage hypertension based on the blood pressure level. That is grading, and staging means divided different hypertensive patients with in those ways or without target organ damage, compensated or decompensated stage. As for the phenotyping, it is not only can differentiate such as white coat or muscular hypertension. At the same time, we can screen for morning or nocturnal hypertension or some special phenotyping such as isolated systolic or isolated diastolic hypertension. At the same time, we also need to screen for the secondary hypertension, just as some hypertension special clinic can be performed, and as well as some special mechanism for blood pressure elevation, including those with higher or active sympathetic nervous activation, or some with a large artery stiffness, and at the same time, more and more Asian population suffer from obesity or overweight. So this phenotyping can give us a very concise and precise diagnosis of different phenotyping of hypertension. So how to evaluate or make a measurement of blood pressure? We can see that the office blood pressure is still the fundamental of hypertension management, including the BP target in different clinical trials and clinical practice, but we still need a step-by-step hypertension management strategy that is on the basis of office blood pressure at goal. We need to realize a 24-hour BP control, and at the same time to try our best to reduce blood pressure variability and improve the time in target range to provide the cardiac, renal, and brain protection, as well as the events prevention. As for the office blood pressure, we can see that in the different country or regions across Asia, most of countries have the hypertension grading with grade 1, 2, or 3, but it is not for the 3 grading system, such as in South Korea. They just step to the US grading system. That means only grading hypertensive population in 2 category. But the BP target, the most of countries agree with that the general population or suffer from hypertension, we need to reduce blood pressure below 140/90, and 130/80 is a further blood pressure target if the population could be tolerated, including those with high risk or with complications such as coronary heart disease or with chronic kidney disease. As I mentioned before, that the 24-hour BP is much more important beyond the traditional office blood pressure, because there is accumulated evidence demonstrated that 24-hour blood pressure is more associated with major adverse cardiac events or as well as all-cause mortality. The data from international database of ambulatory blood pressure monitoring, we can see that the 24-hour BP can be most strong or strongest indicators for the MACE or cardiovascular mortality as compared with office blood pressure. And in recent years, the evidence is also accumulated, such as in a recent paper published in the Lancet. The data from a Spanish nationwide ABPM registry, the analysis demonstrated that nocturnal blood pressure is the strongest indicator for cardiovascular death or even all-cause mortality. In addition to nocturnal hypertension, morning hypertension is a very popular phenotyping of hypertension across Asia. Some data also demonstrated for the morning blood pressure and the prognosis of CKD. We can see from this slide that as compared with those with morning blood pressure, in controlled. Those with uncontrolled morning blood pressure indicated a poor progression for the chronic kidney disease. And in addition to the blood pressure level, the elevated blood pressure variability is also a strong indicator for the poor prognosis of hypertension patients, as well as those suffer from CKD or cerebral vascular disease. So from this slide, we can see that the 24-hour blood pressure variability is increased and associated with the severity of the CKD, and those with higher blood pressure variability had a even worse prognosis or outcome, such as the renal progression or even cardiovascular events and the all-cause mortality. So it is very important for perform 24-hour blood pressure monitoring. We are here recommended the patients who was first newly diagnosed with hypertension, or those with coronary heart disease, with heart failure, acute stroke or CKD, or with or without hemodialysis, and those with diabetes and peripheral artery disease, as well as those with obstructive sleep apnea or anxiety, should be a special population who will benefit for the 24-hour blood pressure monitoring. Traditionally, we recommended a standard 24-hour ambulatory blood pressure measurement. If these devices are not accessible, some other type of out-of-office blood pressure measurement, such as home blood pressure measurement, even those with property of nocturnal blood pressure measurement devices of home blood pressure monitoring, and some validated variables could be alternative options for 24-hour blood pressure monitoring. As for the treatments for 24-hour BP control, we strongly recommended the using of long-acting antihypertensive medications. The 5 class of BP lower medication, including diuretics, beta blockers, CCBs, or ACE inhibitors, or ARBs, are recommended in different countries' hypertension guidelines. If available, such as some new blood pressure lowering medications as ARNIs can also be used for 24-hour BP control. Here we recommended using the long life agents and some with control release formulations. In clinical practice, most of patients still need optimized combination of 2 or more BP lower medications to achieve perfect 24-hour blood pressure control. And the BP target for 24-hour control is the average BP for 24-hour blood pressure is below 130/80, and during the daytime or even for the morning, blood pressure should be reduced below 135/85. As for the night blood pressure target, 120/70 may be the recommended target. In addition to the blood pressure control, we are still address to reduce 24-hour blood pressure variability, because there is much more evidence indicating that standard deviation more than 12.8 millimeter mercury, indicating more cardiovascular risks. So the target should also be reduced below 8, below this threshold, despite the fact that the strong evidence is still absent. As for the treatment options, there is some evidence indicating that live in CCBs, such as like diuretics, have the priority to reduce blood pressure variability. And at the same time, most of people still need to combination therapy to maximally to reduce blood pressure variability. And we should pay specific attention for those such as with severe atherosclerosis, arteries stiffening, or those with previous stroke and advanced CKD. Such population should be performed 24-hour blood pressure variability evaluation. As for the long-term blood pressure management, it is a critical way to achieve high-quality hypertension management and reduce renal and cardiovascular complications. At this stage, the home blood pressure monitoring should be used as a primary approach to evaluate the long-term treatment effects. And at the same time, long-term blood pressure variability and time in target range also are a very important tool for the long-term blood pressure management, as many accumulated evidence indicated these parameters are predictors for a poor outcome of the hypertension and those with other complications. We also recommended some new technologies, including digital tools, apps, or platforms can be used for long-term hypertension management. When we refer to the visit-to-visit blood pressure, there is a lot of evidence indicating that it is associated with major adverse events and all-cause mortality in different populations. And the time in target range also receive much more attention in recent years, as also there is a lot of evidence indicating that the different TTR level means different prognosis in hypertension and those with complications. From this slide, we can see that the total cardiovascular disease events or total stroke is associated with a very low level of TTR as compared with those at high level, or at 1% of time in target range. We can see that the tight blood pressure control also provided even a better prognosis for kidney endpoint. And the study here also a post hoc analysis of SPRINT and ACCORD give us a very important information that the TTR during the follow-up can have great influence on the prognosis of those patients with hypertension, high-risk hypertension, or those with diabetes. As for the long-term blood pressure variability, we can see there is some evidence from the studies. We can see that at the tertiary of blood pressure level and tertiary of the blood pressure variability, the data indicated that at the third tier of blood pressure variability, which means visit-to-visit blood pressure variability above 13 millimeter of mercury may indicate a higher instance of cardiovascular complications. And we recommended a threshold of standard deviation of less than 13 millimeter of mercury of long visit-to-visit systolic blood pressure variability may be a reasonable target. And this target also endorsed by some consensus paper previously published by the European Society of Hypertension blood pressure variability working group. As for the TTR cutoff and target range, we recommended here that for home blood pressure monitoring, the systolic blood pressure target range should be reduced below 135 and above 100 millimeter of mercury. And if we refer to the office blood pressure TTR, the office blood pressure of the systolic blood pressure should be controlled between 120 to 140 or 110 to 130. As for the best time in target range, we recommended during the long-term follow-up more than three-fourths or even more than 75% at goal should be a better target time in target range. And in recent years, we can see some digital therapeutics has been used for management of hypertension. We still need some new technology, including variables and some mobile apps to help us to perform or realize the high-quality hypertension management. So if we make a summary of the high-quality hypertension management recommendations, we here. First, we strongly recommended a very comprehensive and accurate blood pressure measurement, especially for those with out-of-office blood pressure monitoring tools such as ABPM, home HBPM, or some validated variables, and individualized treatment strategy based on blood pressure grading, staging, and phenotyping is also recommended. And as for the treatment, the patient's education is and the lifestyle modification is fundamental for hypertension management. And to realize perfect 24-hour blood pressure control and to reduce blood pressure variability, we need to use long-term, long-acting antihypertensive medications, and to reduce blood pressure variability and improve the time in target range in the long run. And early combination therapy, especially for those with single pill combinations, could provide a better blood pressure control and better compliance, just as Professor Reno mentioned previously. And finally, the digital tools and platforms can make some help to perform high quality hypertension management. I think that with this document, the clinical doctors can have some indications and I hope very better blood pressure control in the near future in Asia. Thank you. Thank you very much.
Thank you very much, Professor Liu. And now we go to the third presentation. Hypertension is not enough. Rethinking cardiovascular risk. Professor Belma Poskic from Bosnia and Herzegovina. Please, Belma.
Thank you. Do you see my presentation?
Yes, yes, we see.
Okay. Good afternoon to everyone, distinguished colleagues. Thank you for your kind invitation for this prestigious meeting, and greetings from Bosnia and Herzegovina. This is my disclosure slide, nothing to disclose. And learning objectives of these presentations are understanding residual cardiovascular risk, recognize limits of blood pressure control, and integrating lipids, inflammations, and metabolism. So over the past several decades, our knowledge about hypertension has advanced tremendously, and owing to large epidemiological and randomized trials, we thought much about hypertension, and we now know how to treat, how to diagnose, how to prevent hypertension. And owing to that, global blood pressure levels have modestly declined. However, the prevalence of hypertension continues to rise, and that is...
Professor, I'm so sorry for that interrupt, but you still not sharing.
Yes.
We cannot see your screen share. Could you please maybe share and reshare, please?
Do you see now?
Actually, not.
No.
No?
Still not see your screen, yes. Maybe you can just
I'll do it again.
yes, just share again, because now we still cannot see your screen.
Do you see it now?
Yes, now it's okay. So
Yes.
It's okay. Please make it a full screen.
Okay.
Okay.
Okay. May I continue?
Yes, full
Yes.
screen. Okay. Thank you.
Okay, thank you. So Bosnia and Herzegovina meet that global challenge with more than 40% patients, adult population with hypertension. Shortly, I will pass through the landmark of hypertension trials. And of course, we should always start with 1948 and the Framingham Heart Study, which established hypertension as a major cardiovascular risk factor. Well, there is a 1998 HOT trial with evaluated optimal blood pressure targets, and I would finish with accord blood pressure and the SPRINT trial. They had intensive blood pressure control in diabetes and non-diabetic patients. So hypertension remain major risk factors, and big epidemiological research taught us that cardiovascular risk increase continuously with blood pressure, starting already with 115 per 75 mercury degrees, and doubles with every 20 to 10 mercury degrees increase. SPRINT trial changed our management of hypertension, and there were they had patients with high cardiovascular risk without diabetes, and with intensive blood control reduced cardiovascular events on that level. That trial stopped early due to benefit. From the point of view of today's presentation, message is that there were intensive blood pressure control but cardiovascular events still occur. So hypertension is not simply a binary diagnosis, and it represents a continuum of vascular injury. Why is blood pressure control not enough? Because blood pressure is only one component in cardiovascular risk overall, but also in residual cardiovascular risk. And the definition of residual cardiovascular risk. It is a persistent risk of cardiovascular events, myocardial infarction, stroke, damage of target organ, and cardiovascular death, despite optimal treatment. So it's observed in very well-controlled blood pressure patients. Blood pressure control obviously is not enough because there are some other components which influence as underlying mechanism in cardiovascular risk. It's dyslipidemia, inflammation, thrombosis, metabolic dysfunction, obesity, diabetes, chronic kidney disease, and emerging biomarkers. We know that key drivers of residual risk are atherogenic lipoproteins, inflammation, and metabolic dysfunction. So LDL-C reduction is one of the most successful stories over the past 3 decades. And in prevention of cardiovascular events. And in that point, lipid story meets hypertension story because reduction LDL it's not enough to eliminate cardiovascular events. So our attention has been shifted to the other atherogenic lipids like non-HDL and ApoB. Nowadays, knowledge is that lipid residual risk is consistent of LDL-C and non-HDL as key drivers. Hypertriglyceridemia contributes to that risk, and the ESC/EAS guideline recommended us aggressive LDL targets in high-risk patients. This is a very well-known chart from this recommendation. And we have a recommendation for very aggressive lipid management, but also we have a recommendation how to assess risk with other components. And among all of these markers, one of them deserved really special attention, and this is non-HDL cholesterol. Non-HDL cholesterol represents a total atherogenic burden. It consists of LDL, lipoproteins, remnants, IDL, VLDL, lipoprotein little a. So it's a better predictor in many patients, especially when triglycerides are high or there is obesity or metabolic syndrome. So it's very easy to have it. We calculated it with subtracting HDL cholesterol from total cholesterol, and the target is LDL-C goal in a patient's plus 0.8 millimole per liters or 30 milligram per deciliter. Beyond the absolute values of lipids, there are lipids ratios. They give us better input in metabolic and risk profile of our patients. Ratio triglyceride to HDL is a surrogate marker for insulin resistance, and the ratio non-HDL to HDL show us balance of protective and damaged lipoproteins. So there are more informative than single values, and the higher is the ratio, the higher is cardiovascular risk for our patients. Jupiter trial changed our thinking about atherosclerosis. in Jupiter trial enrolled patients with a normal LDL-C, but elevated high-sensitive C-reactive protein, and they were treated with rosuvastatin, which reduced MACE by 44%. So we learned that atherosclerosis is both lipid and inflammatory disease. And this study raised high-sensitive CRP as a marker-independent risk factor for low-grade chronic inflammation. And today we have a high-sensitive CRP as independent cardiovascular risk factor. And also we can grade it risk with level of high-sensitive CRP. Jupiter trial, Cantos, Colco trials, they all targeting inflammation and supports inflammatory hypothesis. So today we think that inflammation is not merely a marker, it is therapeutic target. One of the big contributors to residual cardiovascular risk is metabolic syndrome. It's driven by insulin resistance and lead to abdominal obesity, atherogenic dyslipidemia, chronic low-grade inflammation, endothelial dysfunction, and everything what proceeds from those conditions. So can we reduce residual risk? Obviously, with standard approach, it is not possible. And that is why pathophysiology is not fully covered by standard therapy, because residual risk reflects mechanism not fully addressed. So today we know factors which contribute to residual risk, and we got new therapies. So for inflammation, we have colchicine, for lipids, PCSK9 inhibitors or inclisiran, for metabolic syndrome, GLP-1 receptor agonist, for cardiorenal syndrome, SGLT2 inhibitors. So residual cardiovascular risk is one target, one risk, one target, but there are multiple pathways and multiple therapeutic targets. Today we think that there are at least three major components for residual cardiovascular risk: inflammation, residual metabolic risk, and residual thrombotic risk. And we are offered with some therapies for all those conditions. But when we assess patients' risk, different patients has different residual risk. So some patients need therapy for inflammation, some from residual thrombotic risk, and then we are moving to precision medicine to personalize our therapy. How to integrate residual cardiovascular risk into everyday clinical practice? In Europe, we have a score 2 risk assessment from ESC guideline, which allow us 10-year risk assessment of fatal and non-fatal event, and allow us individualized treatment decision. Among all standard factors, risk factors, this score incorporated non-HDL cholesterol, and also it is with a regional calibration for risk, because all parts of Europe haven't the same risk for cardiovascular events. Well, I mentioned that cardiovascular prevention is moving toward precision medicine. So we here have two patients with the same or similar cardiovascular disease and the similar therapy. And the patient on the left, he has a high LDL and the normal high-sensitive CRP. And the patient of the right, he has low LDL and the high-sensitive CRP. So from this point, the therapy should be different. The patient on the left, he should have additional LDL reduction, and the patient on the right, he should have additional inflammation reduction. We should always search for target organ damage for left ventricle hypertrophy, microalbuminuria, or carotid plaques. Well, it's very important to find this target, this organ damage, because in that moment, our patient is not only patient with hypertension, he is patient with vascular disease, and in our prevention in this moment can make a great difference for future events and be more helpful in this stage than that we help after some cardiovascular events. So after all of this, we need integrated therapeutic strategy, and as in her very informative, excellent presentation said Professor Rano, single pill combinations improve adherence, intensive lipid lowering, lifestyle modification, glycemic control, but what is for residual cardiovascular risk? When we offer our patients medicaments, it will be more than maybe 2, 3, 5 medicaments for treatment of residual cardiovascular risk. So we should think of, for future, maybe to some single pill combination for those patients and to improve adherence. So for take-home message, blood control is necessary but not sufficient, as Professor Hingin told us. Total cardiovascular risk assessment is essential. Multimedial approach reduces residual risk, and hypertension is a systemic vascular disease. So for message on the end, treat the patient and not just the numbers. Thank you for your attention.
Thank you, Professor Belma. And the final presentation goes to Yibang Cheng, and the topic is associations of brain morphology and cognitive function with ambulatory estimated PWV. Please, Professor Cheng.
Yes, can you see my slides?
It disappeared. Can you share again?
Yes, okay. Is it visible?
No.
Now? Here's my slides.
It's okay.
Yes, it's okay.
Yes.
Yeah. Good afternoon, everyone, and I'm honored to have the opportunity to share with you our recent research on the associations with brain morphology and cognitive function with ambulatory estimated pulse wave velocity. And I am Yibang Chen from Shanghai Institute of Hypertension. With the global population aging, the number of people living with dementia was rising rapidly. The WHO estimated that by 2030, nearly 78 million people will be living with dementia, and the number may rise to 139 million by 2050. As one of the major causes of disability and functional dependence in older adults, dementia profoundly deteriorates quality of life. Pulse wave velocity is one of the most widely used markers of arterial stiffness. When arteries become stiff, the pulse wave velocity travels faster, and more pulsatile energy may reach vulnerable organs such as brain. Although the brain constitutes only 2% of the total body weight, it is densely vascularized and with high flow and low resistance perfusion, receiving up to 20% of the cardiac output. This results in a close coupling between cerebral blood flow and systematic hemodynamics. Increased arterial stiffness transmits excessive pulsatile energy into cerebral microvascular culture. As a predictor of cerebral small vessel diseases and tau burden accumulation in hypertensive subjects, arterial stiffness may contribute to cognitive decline. Although the pathophysiology link between arterial stiffness and cognitive decline, evidence from population studies remained controversial. In this Rotterdam study, Poise and colleagues reported that higher pulse wave velocity was associated with larger white matter lesion volume. However, the structure changes failed to transfer into cognitive decline when considering other risk factors, including blood pressure. A meta-analysis, including 29 cross-sectional studies and 9 longitudinal studies, reported that an inverse relationship between arterial stiffness, measured by pulse wave velocity, and cognitive function, including global cognition, executive functions, and memory. These inconsistent findings may be explained by the limited sensitivity of cognitive tests. Consistent with the findings in the Rotterdam study, the Framingham offspring study confirmed the association between cerebral small vessel diseases. Higher CF carotid femoral pulse wave velocity was associated with lower total cerebral brain volume, greater white matter hyperintensity, and a higher prevalence of silent cerebral infections. However, the association with neurocognitive outcomes did not reach statistical significance. The structural brain changes may precede cognitive decline and serve as an earlier marker of neurodegeneration. Another potential explanation is the failure to account for the diurnal pulse wave velocity variation. Previous studies mainly relies on a single office visit for PWV measurements, with the carotid femoral PWV as the predominantly method. Similar to blood pressure, the pulse wave velocity also exhibits diurnal variation. Therefore, an ambulatory approach to assessing 24-hour PWV may be a more precise method of real-life vascular load. Therefore, in a study of 84 community jury individuals measured ambulatory PWV, they revealed that only nighttime PWV rather than daytime PWV was independently and inversely associated with global brain atrophy. Considering the limited evidence regarding 24-hour pulse wave velocity and cognitive decline, our study aimed to analyze association between 24-hour PWV and both dementia-related MRI markers and cognitive function in hypertensive patients. Participants were consecutive patients hospitalized at the Translational Research Ward of the Department of Hypertension, Rethinking Hospital. Of the 1,987 patients aged over 50 years old and underwent central hemodynamic recordings from February 2021 to April 2025, 893 were included, of whom 270 with isolated brain MRI data, 348 with isolated cognitive function assessment, and 275 with both measurements. Ambulatory and carotid femoral PWV were assessed by mobile graph and sphygmocal respectively. The brain MRI was performed using 3.0 Tesla MR scanner, Regions of interest volumes were estimated and quantified based on the Cobra Atlas in the CAT-12 toolbox. And as regions of interest volumes, including white matter hyperintensity, hippocampus, parahippocampus, gyrus, and other regions, were assessed. As is shown in this figure, the areas of white matter hyperintensity were marked in pink. So the more area of pink, the higher WMH, the white matter hyperintensity. The global cognitive function was assessed using the Chinese version of MMSE and MOCA tests via face-to-face interview with a well-trained technician. The mild cognitive impairment was defined using education-adjusted cut-off points. We performed both categorized and continuous analysis to assess the association of ambulatory PWV with brain morphology and the MMSE or MOCA tests. In patients who had both ambulatory and CFPWV measured, concordance between the two PWV measurements was studied. Multivariable linear regressions were performed to explore the association between the two PWV measurements and the brain morphology after mutually adjusted one for another. Sensitivity analysis was also performed in subgroups. As shown in this correlation matrix, you may have noticed there are strong correlations between cognitive function and brain morphology. Among all the regions of interest estimated in the current study, we focused on the volumes of white matter hyperintensities, hippocampus, middle temporal gyrus, and superior parental gyrus, which were significantly associated with MMSE and MOCA scores. The 893 study participants had a mean age of 67.2. Over half were women, and the diabetes rate is 39.2. The mean level for 24-hour systolic over diastolic blood pressure was 129.7 over 78.6 millimeter of mercury. The 24-hour ePWV averaged 9.5 meter per second. Diurnal variations could be observed in blood pressure, pulse rate, and pulse wave velocity. Systolic diastolic blood pressure significantly decreased from daytime to nighttime by 6.3 and 6.6. And the same trend was observed for the pulse rate and pulse wave velocity. For the pulse rate, it decreased by 9.3, and for the pulse wave velocity, it decreased by 0.2 meter per second. Distribution of white matter hyperintensities and hippocampal volume stratified by sex and age groups was shown in this slide. The blue box indicates men, and the red box indicates women. Men compared to the women had a larger total intracranial volume and hippocampal volume, and tend to have higher white matter hyperintensity volume. In both sexes, white matter hyperintensity volume was significantly higher in older age, whereas the opposite trend was true for the hippocampal volume. Across 24-hour estimated pulse wave velocity quartiles, patients with higher PWV tend to be older, have higher plasma glucose, lower eGFR, higher LDL serum cholesterol, higher systolic blood pressure. Concurrently, we observed significant trend of increasing white matter hyperintensity and decreasing hippocampal volume and MMSE and MOCA scores. A A significant gradient was observed, with white matter hyperintensity volume increased from 4.39 to 9.24, and the hippocampal volume decreased from 6.81 to 6.21 milliliter. The decreasing trend remains statistically significant after full adjustment. The volumes of middle temporal gyrus and superior parental gyrus was also exhibited inverse association across 24-hour PWV quartiles. In analysis, adjust for the total intracranial volume. However, this trend rendered to non-significant after full adjustment. We further compared ambulatory PWV distributions in patients with and versus without mild cognitive impairment, which was defined by the MMSE or MoCA tests. As shown in the slide, the red box indicates subjects with mild cognitive impairment, and the blue box indicates those without. Compared to the subjects without MCI, those with impairment tend to have higher nighttime pulse wave velocity when MCI was defined by MMSE. And when MCI was defined by the MoCA scores, there are significant higher 24-hour daytime and nighttime pulse wave velocity in patients with MCI compared to those without mild cognitive impairment. In continuous analysis, the multivariable regression analysis shows that each one standard deviation increment in 24-hour pulse wave velocity was significantly associated with 2.0 milliliter greater white matter hyperintensity and 0.54 smaller hippocampal volume in fully adjusted model, including 24-hour systolic blood pressure. The results were consistent when 24-hour 24-hour pulse wave velocity was replaced with daytime and nighttime PWV. In addition, the daytime to nighttime changes in PWV were significantly and inversely associated with the white matter hyperintensity. In other words, smaller daytime to nighttime PWV changes or relatively higher nighttime PWV level was associated with higher white matter hyperintensity changes. Further analysis showed consistent results for 24-hour daytime and nighttime PWV in relation to the brain morphology changes in subgroups. A subgroup analysis was performed to compare the carotid-femoral and ambulatory PWV in 625 subjects. The correlation coefficients, interclass correlation coefficients, and the blend autumn methods showed the mild agreement between the two PWV measurements. Among the 360 subjects with both measurements, we found that ambulatory PWV, whether 24-hour, daytime, or nighttime PWV, was significantly associated with white matter hyperintensity and hippocampal volume. However, carotid femoral PWV itself showed no such association. When we mutually adjusted ambulatory PWV for the CF PWV, significant associations persisted. In conclusion, higher ambulatory PWV was independently associated with lower hippocampal volume and greater white matter hyperintensity, even after adjusted for blood pressure and other covariables. In contrast, carotid femoral pulse wave velocity itself showed no independent associations. These neuroimaging deterioration were paralleled by declines in MMSE and MoCA scores. Targeting arterial stiffness presents a promising strategy for dementia prevention. That's all. Thank you.
Show that 24 hours is different for the diagnosis is so now so on. And just wondering, patients with long-standing arterial hypertension without organ damage.
Excuse me, Professor Malcolm, I'm so sorry, but we cannot hear you well. But,
要帮助他人比自己心态好，就是你吐槽在你的嘴下面或扶手中间，水上或者取出石榴，头部穿好，带子从后向前扣好，在壳层内不要抽屉。
excuse me, Professor Miracle, we still cannot hear you clearly. Maybe there's some issue or not.
I want to ask Professor Liu about in his presentation. He showed that 24 hours blood pressure monitoring is reserved for patients with newly diagnosed arterial hypertension. I am just wondering whether it is not needed for patients with long-standing arterial hypertension without target organ damage, just only for assessing the efficiency of treatment. Just is it efficient treatment or not? You don't mention about long-standing arterial hypertension without or target organ damage. Should we do it for these patients blood pressure monitoring 24 hours or not?
Thank you for Professor Erking. It's a very important question because we recommended, if available, those who are firstly attended to a hospital or clinic should be performed 24-hour ambulatory blood pressure monitoring to give some precise diagnosis of hypertension. That means the level of BP during daytime, nighttime, as well as some screen of such as white coat hypertension, muscular hypertension. So 24 ABPM is very important if available or accessible. We recommend for every patients who are firstly come to the clinic to for diagnosis of hypertension or screen for hypertension to perform this out of office blood pressure measurement. As you mentioned, I know that you are mentioned if the patients without target organ damage, but we think we still need to make some precise diagnosis for those patients.
Just to repeat blood pressure monitoring, yes. We need to repeat patients to not to stop, but to repeat periodically blood pressure monitoring for long-standing arterial hypertension.
Yes.
For assessing the.
Yeah. It's also another important question because the reproducibility of ABPM in general, it is very good. So if the resources are available, we recommend it to repeated 24 ABPM in the next several weeks before the first ABPM was performed.
Okay, and next question also for you, Jing. You mentioned that the target of blood pressure should be within 5 times you need to measure blood pressure 5 times within 2 weeks. Usually we recommend to do a home blood pressure monitoring in the morning, daytime, and evening. Is it enough 5 times within 2 weeks?
The question for me?
Do you hear me?
Sorry?
Yes, question for you.
Yeah.
Yes.
You means home blood pressure measurement?
Yes, home blood pressure measurement, you said that it's 5 times within 2 weeks. But usually we recommend to measure in the morning, daytime, and evening.
Yeah.
Is it enough 5 times within 2 weeks? Is not limited?
Yes. In Chinese hypertension guidelines for home blood pressure monitoring, we recommend it for maybe 3 to 5 consecutive days monitoring of home blood pressure, and we if in the patients who was firstly receive medications, we can repeat it, the home blood pressure monitoring during the next few weeks to assess the treatment effects of blood pressure lowering effects.
Okay, and one question to Dr. Cheng. Do you compare the morphological parameters of brain morphology with mental or psychological parameters? Is it any connection between morphological changes and mental or psychological changes in behavior of the patients?
Thank you for the question. Actually, we didn't collect this data from the for the behavior habits, and I believe these behavior habits may be such as we have collected behavior such as smoking and drinking, and these smoking and drinking were well-known risk factors for the deterioration of cognitive decline, and also the well-known risk factor for the brain for the white matter hyperintensity. We included these risk factors in the model, and since the other risk factors such as the emotional changes, we didn't include it. So that's all.
Okay, thank you. Any questions?
Professor Eric, can I raise 2 questions?
Yes.
Oh, thank you very much. It's very interesting afternoon, and thanks all the speakers to give such a great presentations. And I have 2 questions. The first one is to Professor Renaud and Professor yes, but because we know that regarding of the ASCVD, hypertension is only one of the major risk factors. Also, the high level LDL-C and diabetes of obesity is also risk factors. So regarding to the FDC, to prevent our hypertensive patients from ASCVD, can we consider more FDC combined, not only the hypertensive pills, but also lower LDL-C and also anti-diabetes? We consider these FDC, SPC, there will be more benefit for our hypertensive patient, right? And so if we consider this, how can we do in the future to produce these kind of agents for our hypertensive patients?
Thank you for this very interesting question, because we come to the era when we should to treat it not only the disease and should treat the patients. And personality, it's very important. because all patients are different and they have a completely different diseases and situation. And I absolutely agree that recognitions and combinations of drug, it should to be beginning with patients with the very high risk of MACE and cardiovascular disease, even from different groups. We should be treated the patient and comprehensive, not the disease. And in my practice, in our country, we have the combination drug with not only the antihypertensive type drug, but including the statin, like rosuvastatin and combination with ezetimibe. And the triple drugs very useful for our patients with very high risk of cardiovascular MACE. That's it.
Thank you, Professor Rova, and thank you. And the second question is for Professor Yibang Chen, and I'm very interested in brain health in hypertensive patients. We are also doing some research regarding to the brain health, and it's very interesting for us to know that PWV is associated with increased WHB, right? So it's very interesting. So if we know that because higher higher.
You mean white matter hyperintensity?
WMH, yes,
Oh.
higher WMH is associated with not only the cognitive decline, but also maybe stroke, maybe depression. So you mentioned that if a patient have higher PWV, they will have more risk factor, more risk to have increased WMH. So do you have any because PWV is not very it's not very convenient for every centers to measure. So do you have any other surrogate for us to consider? It may be very related to higher increased WHV. And the second one is that if we know that our patients have these higher WMH, how can we treat them? Which medication can we to help them to increase their brain health? Thank you.
Thank you so much for these questions. And the first question is about the use of pulse wave velocity in clinic utility to increase the risk rectification and for the patients who tend to have higher risk for the white matter hyperintensity. And in my opinion, as has been reported by previous studies, they also reported the estimated pulse wave velocity. I mean the formula-based pulse wave velocity, which can be calculated by the age, by sex, and BMI and other risk factors. It has been reported to be associated with the brain deterioration. And many studies, including the Sprint Mind studies, they also did the subgroup analysis. They found that the patients with better response to the PWV reduction in response to the antihypertensive drugs may have the lower rates in the cognitive progression. So the PWV could be used in such patients who are not available to have the PWV measurements, but we can calculate the indices. And then the second question is about the treatment. Actually, till now we don't have the so many effective drugs to prevent the progression of the white matter hyperintensity. However, several drugs may indicate to have the better predictive value, such as antiplatelet drugs and the Niger such as antiplatelet drugs, and this was also inconsistent with our studies. Based on in our studies, we have previously published a meta-analysis to explore the effect of antihypertensive drugs, different kinds of antihypertensive drugs on the hemodynamics, and we found that different drugs have different effects, especially for the central hemodynamics, which is very close to the cerebral microvascular culture. So we believe that the different drugs, especially for the antihypertensive drugs, may have different effect on the outcomes. Yes.
Thank you, Professor Chen.
I have two questions for Dr. Chen. So it's a very interesting study. One is that I want to know whether you do some subgroup analysis about the diabetes or the blood glucose will affect the result. We all know that some diabetes patients usually the cognitive function will be declined.
Yeah. I agree with you. I totally agree with you. And we did the group analysis in patients with diabetes, and you may have noticed the relatively higher prevalence of diabetes in our groups. Nearly 30% patients have diabetes. It's because it is patients in clinic. And we didn't find a difference between patients with and without diabetes. The association between PWV and the outcomes were consistent.
Thank you. A second question is that in your study, we can see you use the CPWV, but the association is don't have. But how about the BPWV? Because BPWV is very easy to get in the clinical. Yeah.
Yeah. We measured breakaway ankle pulse wave velocity, but we didn't report the results because previously in the Kairuan study, they have already reported the similar trends as observed in their study, and they have a larger population. And the main results or the main focus of our study is the superiority of ambulatory pulse wave velocity over the office and one single visit of pulse wave velocity measured by also correlative femoral or breakaway ankle pulse wave velocity.
Thank you very much.
Okay, thank you very much.
Our time
Anybody
is
has
over.
question? Yes,
No.
yes. Just I want to thank all our attendees, all our speakers, and all Asian Heart Society team who support us during this session. I think the session was very interesting. It is proved by overtime. We have 10 minutes overtime, but it's proved that our session was very interesting. And if it is not limitation of time, we can continue. But I want to say thank you very much to everybody and see you soon. Thank you. Bye-bye.
Thank you. Bye.
Bye.
Bye. Bye.
Bye-bye.
Bye.
Bye.